Okay, thank you all for giving me this opportunity to talk about Evolute in degenerated surgical bioprosthesis. I'll present a quick case and then a very quick slide deck to put my difference why Evolute should be the definitive choice for degenerated valve-in-valve cases. Okay, and I have to figure out how to, okay, here we go. So this is the case details, 77-year-old male. He had a previous bypass surgery and aortic valve replacement using a Carpentier Edward bioprosthetic perimount 21 millimeter valve. That was done about 10 years ago. Now he presents with dyspnea on exertion. On echocardiogram, it is quite obvious he has got bioprosthetic degeneration with moderate aortic stenosis and a mean gradient that was around 32 to 34, but severe aortic regurgitation. A TE was done, which failed to show any paravalvular pathology. So that was a transesophageal echo, which concurred the diagnosis. Rest of the heart was pretty unremarkable. His left ventricular function was normal, and there was very minimal mitral regurgitation. We did a pre-procedure coronary angiogram, which showed patent grafts and a native triple vessel disease. We planned a transcatheter aortic valve replacement, valve-in-valve using Evolute. These are some of the measurements that you can see. The annular measurement, as Dr. Prasad was mentioning, that many of the times we can't just blindly go through a valve-in-valve app, although for most part, it does pretty good job. So these are some of the internal measurements. You can see these measurements are consistent with a 21 millimeter perimount valve which was implanted. And there isn't big pannus or any other soft tissue growth that you can see. The sinuses were quite wide, with individual sinuses measuring more than 30 millimeters in diameter. Left ventricular outflow tract was okay. There was no any significant calcium. The measurement itself for the LVOT becomes less relevant in these cases because for most part, LVOT perimeter or area is larger than the surgical valve which has been placed. The ascending aorta was a little bit generous, but about 40 millimeters, which was acceptable. A little bit horizontal aortic plane, more than what we want in a straightforward case, but a 61 degrees certainly is reasonable to manage. And this is the VTC, or the valve to chondria distance, that again Dr. Prasad was mentioning. And we ideally want more than 6 millimeters of VTC distance. And I typically, when I measure on the outside of the stent struts or the valve posts. And here you see the measurements are certainly beyond 6 millimeters. On the right side, it's about 8, and on the left side, it's about 9. So it's well beyond 6 millimeters, and we would be okay no matter how we measure this. So from the VTC distance standpoint, we thought we were pretty clean. This is the vasculature. You can see, other than a little bit of tortuosity, the rest of the vascular access was pretty reasonable. The luminal diameters are good, and there is eccentric calcification, none of which is malignant or threatening to us. On the left side also, it was quite reasonable. And because the tortuosity was more or less the same, we preferred to go on the right side as compared to on the left side. This is the summary of all the measurements that I was mentioning about. Particularly, you look at the left coronary height, and that is well above 10 millimeters, but more so, even the coronaries are farther away from the valve posts. So the chances of coronary occlusion, which is higher in valve-in-valve cases, in this particular case, we were not worried about coronary occlusion that much. The procedure otherwise went pretty unremarkable. This is a 23 millimeter Evolute. In the first video, you can appreciate the horizontality of the valve, but overall it opens up quite well. This is at 80%. You take a shoot, you find that the valve is in the right place. Truly speaking, for a valve-in-valve case, we really don't even need to take shoots in the annulus, and we are technically able to minimize the contrast if we have to. The third video shows the release, the slow release for the valve, and you see the stability, and it works out quite reasonable. These are the final images, the final position, and root aortogram, which is done with the pictal in the LV. It shouldn't be, but even with the pictal in the LV, you see there is hardly any leak, and the hemodynamics suggests that there is no gradient. even with that small surgical valve which has been placed. So we did not need to post-dilate or do any valve fracturing. I tend to post-dilate most of my valve-in-valve cases. In this particular case, because the hemodynamic was so good, we decided not to do it and just leave it at that. So after that quick case, we'll just go through 4 or 5 slides. Does the valve choice matters in valve-in-valve TAVR? And this is the early TCT registry. If you take a look at this, almost 1/3 of these cases with TAVR had some degree of patient prosthesis mismatch of moderate or severe degree. And if you track these patients or follow these patients in terms of mortality, you see that patients who have got moderate or severe patient prosthesis mismatch, it does translate to higher mortality going down the line. The patient data set, particularly in valve cases, if you compare balloon expandable versus self-expandable valve, you see across the spectrum, balloon expandable valves tend to have a higher degree of patient prosthesis mismatch as compared to self-expandable valve. This is far more prevalent in those patients who start with a patient prosthesis mismatch of the original surgical bioprosthesis. And there, if you put a balloon expandable valve, you can expect almost 80% of them to have a certain significant degree of patient prosthesis mismatch. And that probably happens because of supraannular versus intraannular design of the 2 valve subset that we have. This was very early data by Dr. DeVere, where he presented the first vivid registry. You get a sense that balloon expandable valve are significantly associated with higher mean gradients at 1 year follow-up. If you divide these patients between in a dichomatous fashion where you take a breakpoint of 20 millimeters mean gradient, then certainly patients with balloon expandable valve, a higher portion of them have a post-procedural gradient of 20 millimeters or more, which is particularly seen in smaller annuli or a smaller valve. The reason why it is relevant to divide up the patient with a mean gradient of 20 or less, because if you go back into the partner 2 registry, valve-in-valve registry data set, these patients who have a mean gradient of 20 millimeters or more, they are associated with significantly higher mortality as compared to those patients who have got lesser mean gradient. Essentially, in common term, that would translate into pretty much converting one entity, which is bioprosthetic valve failure, into another entity, which is significant patient prosthesis mismatch. Balloon expandable valve in univariate analysis of a recent data set has been associated with increased all-cause mortality of almost 3 times. To summarize, valve-in-valve TAVR is associated with higher post-procedure gradients compared to native TAVR, and it had to do with the fact that we are putting a valve within a constrained surgical bioprosthesis. Mean gradient of 20 millimeters or more translates into higher long-term mortality, and this is particularly relevant in patients who had a bioprosthesis size of 23 millimeters or less, or those patients who already has a baseline patient prosthesis mismatch. Self-expandable supraannular valve system like CoreValve or Evolute is associated with lower gradients, and in my opinion, that should be preferred valve in these kind of cases. Controlled expansion, like happens in the recapturable Evolute, it allows for optimal valve positioning in case if you don't like the initial position of the valve. Thank you so much for the opportunity, and we'll be happy to part in any discussion.